Today we're going to talk about newborn assessment and management. To be fully competent and safe when managing newborns, the therapist should have a strong knowledge of all of these things. There are many changes that occur right at birth and over the first 24 hours, so it's important to understand these changes in order to monitor for abnormalities. Like I said in the last slide, there's a lot of changes that happen right at birth, and one of the biggest ones is the changeover from fetal circulation. There are many different complications for both mother and infant during labor and during delivery. These can usually be broken up into maternal factors and intrapartum or during delivery factors. When we're setting up our delivery room, we need to know what's going on in order to make sure we have all the right equipment. There are a handful of questions that we like to ask to help us determine what we need. The first question is the gestational age of the baby. This question really helps us determine what we need by knowing if the baby is term or premature, but a specific age is always helpful because sometimes the size of the equipment you're using needs to be adjusted. The amniotic fluid color is another question. This can be a couple of different things, usually clear, that's what we want it to be. It can also be full of meconium. We want to know what kind of meconium, if it's thick and chunky or if it's just light. The amniotic fluid could also have blood in it. All of these things will change the way we set up for a delivery. The third question is how many babies. This is important because each baby needs their own team to manage them. The fourth question is about cord management. Cord management is talking about delayed cord clamping, which is something that we started doing a few years ago. And basically, when the baby's born, we keep them attached to the umbilical cord for the first minute of life. This is an important discussion to have with the OB because sometimes they get tunnel vision and don't realize when a baby is having problems. So we just remind them that we might need to cut if the baby's not okay. And the last question, which is more of a catch-all, is any additional risk factors. Things that can be included in this question are any other maternal meds that the mom is on or has recently taken, things like substance abuse, or if the mom has diabetes or hypertension or anything like that. So based on those questions, we want to make sure that we have all the right equipment, and these equipment will be outlined very specifically in NRP, but we'll talk a little bit more about that in a few slides. APGAR scoring is basically a quick way for us to relay information about how the baby is transitioning into their life. We will also talk more about this in detail later on in the slideshow. Birth transition goals are basically what we expect the baby to do, what we want them to do. One of the biggest goals and guidelines that we have are the oxygen saturation. Babies aren't born perfectly pink or breathing always, and we have guidelines on how their saturation should be for each minute of life, up to 10 minutes. So we will talk more in a few slides. Tocolytics are medications that are used to stop uterine contractions. We use these when there's a high likelihood for lung immaturity, which is usually based on gestational age, but it can also be shown by lung maturity tests. An example of these meds are terbutaline and magnesium sulfate, or MAG. Some of the side effects of magnesium in newborns is poor muscle tone and apnea, or slow, irregular breathing. So if the mother is receiving magnesium sulfate, you want to be ready to provide PPV just in case the baby doesn't want to breathe for you. Glucocorticoids are helpful in speeding up the development of the fetal lung. It can also reduce the incidence of respiratory distress syndrome and a lot of other things when it's given prior to delivery. It's usually indicated in gestational ages of 24 to 34 weeks when delivery is imminent. Doses can be repeated if the previous course was given more than 14 days ago, and it's one of the common, really the only medication that I've heard used is betamethasone, or beta. So the book outlines the risk factors for both maternal and intrapartum. Maternal risks like diabetes and hypertension or substance abuse bring extra risk to the baby, which we'll talk about later during this class. Intrapartum risks like C-section, breech presentation, and vacuum delivery carry their own risk. Each one of these risk factors brings its own risk to both mom and baby, so it's important to be very familiar with these lists. I'm sure you all know what apnea is, but it's important to know the actual definition. So, apnea is the cessation of breathing for greater than 20 seconds, or any apnea duration that's associated with cyanosis or bradycardia. There are two types of apnea which can happen. There's primary apnea, which is a result of stress from labor and can easily be reversed by just stimulating the baby. Secondary apnea, though, is from prolonged primary apnea when oxygen deprivation is setting in. Tactile stimulation, or stimulation in general, will not be effective. You have to bag these babies, so providing PPV is the only way to get this baby to start breathing. Don't be scared, though, because sometimes it's just a breath or two that will turn this baby around. It might take a few minutes or longer, too. The book has an outline of equipment and supplies you would want to have at a delivery, but we're going to go over just the general ideas. The first thing you want to do is be able to provide warmth for the baby. This generally comes from a radiant warmer. You also want to be able to clear the airway. You want to be able to provide ventilation and oxygen. And you also want to have intubation supplies and medications in case things really get out of hand. Don't forget that with babies and kids, they come in a variety of sizes, so you want to make sure that you have the right size available for the baby that you're expecting. We'll also cover this in more detail in NRP. The APGAR score, like I said before, is a way for us to easily transmit information between one another. If you think of it similar to the Glasgow-Coma score, it's a number that's associated with how well the baby's doing at certain points after delivery. It's based on 5 different categories, the first one being heart rate. We want the heart rate to either be above 100, below 100, or absent. So you can see here on the slide, 2 gives you, to get a score of 2, your heartbeat, the baby's heartbeat has to be over 100. Not your heartbeat, because I'm sure it will be for the first few tries. If it's below 100, but greater than 60 or has any heartbeat at all, we score that baby a 1 point in the heart rate section. If it's completely absent or extremely low, we will give it a 0. Let's just stick with completely absent, just so I don't confuse you guys. In the respiratory effort section, a strong cry from a baby or just normal breathing is given 2 points. If it's irregular or shallow, then they get a 1 point. If they're apneic, 0. Muscle tone, same kind of idea. If they're flexed and acting like a normal baby, they get 2 points. If there's only some flexion, like maybe just their arms or their head or something moving, then they get 1 point. If they're completely limp and flaccid, they get 0 points. Reflex and irritability. So a lot of times what we'll do is watch for them to get irritated when we do something, either flicking their feet. Sometimes I can put a mask on them for CPAP and see if they flinch, or suction. Some videos show them if you just pull the baby's arms, see if they snap back or just fall limp. That's your reflex. So you want to look for them to have a strong reflex. We'll give them 2 points. If it's just a little like wince, they'll get 1, and no response obviously gets 0. And the big one that we look at a lot is skin color. That will dictate a lot of our stuff in the beginning. So completely pink, which almost never happens in the APGAR score, gets 2 points. Blue hands and feet, also known as acrocyanosis, gets them 1 point, and completely blue or pale gets them 0. So you guys want to be able to make sure that you understand how to score a baby given some information, and be able to do that on a test. So if I give you the example of a baby with a heart rate greater than 100, so 120, they have an irregular cry and limp with no reflexes and pale, I want you to think about how you would score that baby. Okay, that would be an APGAR score of 3. So if you're not understanding this APGAR score, please let me know and I can explain it in more detail. This is the newest NRP algorithm. This is the process we use for neonatal resuscitation. If it's done correctly, it works very well. And the nice thing is it's not as complicated as ACLS or PALS. We will discuss this later, but you should take some time to review it and make sure you're able to use the algorithm to answer questions. All right, so let's get into some resuscitation of babies. Right when a baby's born, the first thing we want to do is keep them warm. They are covered in amniotic fluid, which is just like watery substance, and they don't have a lot of brown fat yet. So they have trouble maintaining temperature. And if a baby's temperature gets too low, it creates all kinds of problems. The 2 big ones would be low blood sugar and apnea. So we like to keep them warm. Step 2 is properly position the baby by getting them in the neutral or sniffing position. These are both the same, they're interchangeable terms. Once they're in a good position for breathing, we want to make sure their mouth and nose are clear of any secretions. I want you to remember M before N, so mouth before nose. And after that, after we cleared their secretions, we move on to drying them, which does 2 things. It stimulates the baby and it keeps them warm. If we're done drying them and we still need to stimulate, then we can rub their back and their trunk, or you can flick their feet. Babies really don't like it when you touch their feet. All right, here's a picture of that sniffing position right here at the top. It's the correct position. I think you guys have probably talked about this in other classes. It's optimal position for breathing for babies and adults. So you can see the top one is correct positioning. The middle one is too flexed, or the head is too far forward, and the bottom one is too far extended. So having the airway not in the correct position, you guys probably know this, will make it more difficult for air to get into the lungs. So, when do we need to provide PPV? Well, the easy one is if baby is not breathing at all, but there's a couple of other indications. The second one is if you see a baby gasping. Gasping is a key word and should trigger you to think of agonal breathing or ineffective breaths. The last indication for PPV in the newborn is a heart rate less than 100. When you start PPV, again, you want to make sure they're in the correct sniffing or neutral position, and then you provide 40 to 60 breaths per minute, much faster than we bag adults. If you think of when you're bagging, breathe 2, 3, breathe 2, 3, just like a waltz. And when you say breathe is when you squeeze the bag. But be careful when you're bagging, because unlike adults, we don't just get to squeeze the bag and fill up their lungs. We want to make sure that we're not providing too much pressure. So we start with PIPs of 20 to 25, and you want to keep your PEEP at 5. You'll also look for a slight rise and fall of the chest, but bagging with a flow inflating bag, you guys, is quite difficult. It takes a lot of practice. So much so that NRP and quite a few hospitals have transitioned away from that and started using the T-piece resuscitator, which you'll learn more about in NRP. The way to tell if you're providing adequate ventilation for babies is to see an increase or improvement in the heart rate. And this can happen super fast in as little as 2 or 3 breaths sometimes. So just keep an eye on that heart rate. Okay, now we're on to cardiac compressions. So babies don't usually require chest compressions, and that's because we don't start them unless that heart rate dips below 60, and we've already given 30 seconds of effective ventilation. More on the effective ventilation later. The main reason the heart rate is low in infants is because the ventilation is not adequate. So we want to focus on that as long as we can before we transition on to chest compressions. But sometimes it happens and we have to do compressions on babies. And it's important to know that you really should try to intubate that kid before we start any compressions so that we're not interrupting them while we're trying to intubate. And we know that an intubated patient has effective ventilation, so we will know that it's not that at that point. All right, here we go. More detail about the NRP algorithm. So we start up here right at the top, and we need to find out what's going on. This is where we get our report, or NRP likes to call it a team briefing, but you really just get a picture of what's happening so you can prepare for your resuscitation. Usually this is very quick, just a minute or less, and then we move on to getting our equipment ready, which we will determine by the report that we just got. So, second box or shape here that we want to talk about is after the baby's born, there's 3 questions that we like to ask to help assess the baby. The first one, is the baby term, or is it the gestational age that you were expecting? You guys would be quite surprised at how many times we've been told that the baby was a specific gestational age and turned out to be the opposite. The second question is, does the baby have tone? Tone is a big indicator of how well the baby's doing. And lastly, we want to know if the baby is breathing or crying. So, if the answer to all 3 is yes, we move over here to this section and the baby gets to stay with mom. If the answer to any of these is no, then we move down the algorithm and we position the baby, we dry and stimulate, and keep assessing the baby's breathing. Down here, in these other funny shapes, it's asking if the baby is apneic or gasping. If they are breathing and not gasping, you move over here to the right, where we will assess the breathing for labored breathing, or we'll look at their color for persistent cyanosis. If you see either of these, you should position the airway and consider CPAP. When we go back to the main line, if we had apnea or gasping, we have to start PPV. If you're starting PPV, then you definitely need to put a pulse ox on the baby, and you also want to consider cardiac monitoring. Once you start PPV, you assess the heart rate. If the heart rate is less than 100, you need to perform the corrective steps. Mr. Sopa. More on that in a couple of slides. This will help ensure that you're getting adequate ventilation. If the heart rate's staying below 100, you also want to consider intubation and maybe start getting ready. And after 30 seconds of PPV, you definitely need to assess the heart rate again. If it's still less than 100, you keep going and you want to make sure that it's adequate. If your heart rate drops below 60 after you've been bagging, this patient needs to be intubated and chest compressions will be started. So now we're down here to this section, heart rate less than 60. No, then we can go back up and we're trying to get our heart rate up to 100, so we'll keep bagging. If we are yes, we intubate the baby and we start chest compressions. Once we start chest compressions, we also need to get venous access. The quickest way for babies to have access is through an umbilical venous catheter. This is the way that we will give epinephrine, which is our main drug, to help improve heart rates. And we can also give things like saline or blood to increase the volume that the baby has. I know this is a lot, you guys, but don't worry. You'll go over this lots of times before you're expected to do anything with babies. Just know them and watch when you're in clinic and things like that so you can pick up the nuances of neonatal resuscitation. All right. A couple of things to remember. Whenever intervention is done on a newborn, you need to place a pulse oximeter on a preductal site. Preductal is important because it's the most accurate right after birth. Preductal sites are basically somewhere on the right arm. Usually we put it on the wrist or the hand. Assessing the baby purely on color is no longer the gold standard. It's been proven to be too subjective and quite unreliable. If you look at this table here, our oxygen saturation table, it's a small part of that NRP algorithm, but it's super important. I really use this at almost every delivery. When babies are born, they don't magically have perfect saturations. It takes some time. They go through this transition, and it's quite uncomfortable to see saturations down in the 60s, but that's why we have this chart for reference. So if you look here at 1 minute, the saturations can be as low as 60%, which is acceptable for a baby 1 minute of age. Each minute thereafter, it increases 5% until we get to 5 minutes. And then after 5 minutes, it jumps to 10. And at 10 minutes of life, the baby should be having fairly normal fats, at least 85%. So the way to take this is if you have a baby who's requiring oxygen and they're setting 100% or even in the high 90s and they're only 3 minutes old, you definitely can turn that down because they really only need to be 70 to 75%. Another thing about oxygen is the initial concentration when starting PBV. For term kids greater than 35 weeks, we like to use 21% oxygen. If they're preemies, NRP says that you can go up to 30%, but you can also start at 21. So the way that I make this easy for me is I just start everybody at 21% and titrate based on this table. Okay, last slide. Thank goodness. So, we're going to talk about those corrective steps. Remember Mr. SOPA? NRP has this cool dude called Mr. SOPA that helps you remember how to adjust your bag so that you can effectively ventilate your baby. Each letter has its own meaning, and we'll start with M. M is for mask adjustment, so we want to adjust the mask to make sure we have a proper seal. R is reposition the airway. You want to make sure that you have your baby in that nice sniffing position. S is for suction, so we'll suction secretions out of their mouth and nose. O is for opening the mouth. P is for pressure increase, and A is alternative or advanced airway. So, like I said before, when we adjust the mask, we're trying to get a nice seal. Usually you want to just take the mask off and reapply it. It's the best way that I've found to make sure, otherwise you're fidgeting too much. Repositioning the airway, like I said before, you're trying to get the baby in the sniffing position, and you can look back at the PowerPoint to see what your good positions look like. Suctioning, pretty self-explanatory. You got to clear those secretions. Opening the mouth, kind of a no-brainer. You have to open the mouth to suction anyway, so that one is pretty easy. Now we're down to P, increasing the pressure. This is talking about the PIP. Remember back when earlier we were talking about PPV starting with pressures of 20 to 25? Now we're going to increase those. You can go up to 40, but you only want to go in increments of 5 and need to be very careful when you start getting to 35 and 40 because you have risk of popping a pneumo. Lastly, A, alternative airway. This is where you need to place an advanced airway, which is either an ET tube or an LMA, which is a laryngeal mask airway. Since LMAs are quite limited to term and bigger infants, we don't really use them that much. We just intubate the babies if you get to this step. Hopefully you notice the colored boxes around this because those steps are done in tandem. So you see our green box here, M and R are mask adjustment, repositioning the airway. We do those in one step. When I take my mask off, I reposition the head, put the mask back on, and try to bag. If that doesn't work, I need to move on. I do my yellow box. So I suction and open the mouth. It's been quite effective. Opening the mouth and suctioning, you'd be surprised at how little secretions can make a big difference. Once we get on to our P and A, we only do those in their own step. So we're on to P, which is increasing pressure. And like I said before, you do this in increments of 5. So you'll start at 20, you'll go to 25, give a couple of breaths. If things aren't better, you go to 30. A few more breaths, you can increase again, and we're trying not to have to go to the last step, the alternative airway. Just to help you understand, we are doing this because our baby's heart rate is too low, less than 100. When one of these steps works for you, you will see an increase in heart rate very quickly in just a few breaths. It may not go all the way to 100, but you will see a difference and you can relax a little bit. I know that we always talk about chest rise when giving PPV for babies, but really the only indication that your PPV is working is our increase in heart rate. Okay, that is it.